Hello, everyone. I'm Anup Patel, and I get to talk about the SOML study, which is a PCORI grant. But my fun fact will build on what Dennis had said. I have no musical talent. However, when I was in college, I did have a radio show, and it was a lot of fun. It was with my friend John, and we were the Time Bomb and Roadrunner show. And in Little Springfield, Ohio, we were the #1 rated show and had a little fan base as a result. So it was actually kind of fun, and one of the things I really look fondly on when I think about my past. But before I get into the specifics, I do want to say thank you. I want to say thank you for inviting me and Tracy for organizing. I want to also say thank you to the team that helped put this together. Ann Berg was a big part of that and instrumental in how we started to design and put this together. Tracy has been intimately involved, and you'll see some of the others as well. So that's who I am. My disclosures are I have institutional research funding from the following folks. But what did we want to do, and what was the idea? So in my real life, I like to see if I could compare things and do quality improvement and other kind of aspects of care from that standpoint using existing data. So, we often ask the questions, is one treatment better than another treatment? How do we measure that? How do we do that? And how can we make and learn from that? And the answers are we don't really have great mechanisms or opportunities to do so. So we thought, there's a group of us. Anne brought me into the group, which I really am grateful for. And it was amazing because it was an opportunity to say, hey, are there differences between medications and other types of treatments like surgery? And when we talk about surgery, we're talking about both devices and also palliative options like corpus calcitomy. And how then do we look at other outcomes? You've heard a lot of that today, and I want to highlight some information that we gathered or that Tracy and her group gathered prior to leading up to this study around looking beyond seizures as possible outcomes and looking at to see if there's detectable differences between two groups. And I won't read through the specifics, but these are some of the things that come to mind or came to mind and that you all know exist within our LGS population. So the core team now is those folks here. Sandy is a neurosurgeon at Lurie Children's. Mark is an informaticist and a data whiz at Lurie, and then me, and then Tracy. So we have, the way we've organized it is what we call a high touch and light touch sites. And I'll explain some of our aims in a second, but we're trying to tap into existing data sets to see, first of all, if we can identify patients who have Lennox-Gastaut syndrome, and then what can we learn from the administrative data or data that's already been collected as it relates to these two groups of continued medications versus surgical options. The high-touch sites have to do a lot of chart review, and we're very grateful for that, and I'll kind of go through some of that in detail. So I won't read through the specific aims. I want you guys to be able to read that yourself. But really, again, and the idea is, okay, are there detectable differences in existing data between different treatment options? And then, can we look at that as far as other outcomes related to quality of life, communication, behavior? But how do we go about doing all of that and understanding? The first lesson that we learn and are learning is to listen. And so we'll talk more about that. But that idea is then going to be helpful for us to say, hey, is there real-world information that can help our families, more importantly, and our patients with Lennox-Gastaut syndrome? Feed that back to the people who matter and tell them, hey, this is what we found. Does this resonate? How does that help you in your life? And I think it's a little different approach. Clinical trials, I've participated in several and feel it's very important. But this is a different way to say, hey, let's use existing information and see what we can learn. But to do this, we had to be creative because one of the problems we have is we don't listen, and we didn't listen to our families. So we thought, well, let's put a survey together and see if we could find out lots of different informations. And I'm going to share what we are starting to learn as a result. But the biggest thing is how does your healthcare team interact with you to measure some of these other outcomes outside of seizure frequency? And more importantly, are you aware of tools or information that we should look at or that you would want us to look at, both from a research standpoint, but also from a clinical care standpoint, which is very important. So we sent this survey out to a bunch of people through the LGSF and then also through one of the surgical alliances. And we really wanted to see, hey, do you have LGS? Do you not have LGS? But we wanted you to have epilepsy. So we had to, unfortunately, a couple of people filled it out that didn't have a loved one with epilepsy, so we excluded them. But we had over 132 who had LGS out of the 248 families. And you can see this graph about the age range, which is what you'd probably expect, and nothing that was really surprising. And then we asked, okay, of the people in the survey of the 248, how many of you had surgery? Now remember, we're probably getting a higher number because we also asked a Surgery Alliance advocacy group to help us. But you can see those percentages as it breaks down and what types of surgeries they had. But what was interesting, what we're starting to learn, is that most caregivers didn't know if they had actually completed a validated assessment tool for communication or behavioral or quality of life. And they also unanimously agreed that we should do it, that quality of life is really important. You should ask me about my child's behavior. You should ask me about communication. And then fewer than half of the caregivers agreed that any of the three domains were evaluated well by us as healthcare providers. And what we are learning is it matters, and what matters to families. And you can see the differences between the people who thought that their caregiver or their healthcare provider effectively communicated these domains versus how important they are. And you see this big disconnect between the two, which I think is striking and says we've got a lot of work to do. And what's interesting is only 41% agreed or strongly agreed that our ability to do that was good overall, and specifically same sorts of information in behavior and quality of life. But when you look at the LGS versus the non-LGS caregivers, there was a significant difference around communication, and the fact that in the non-LGS, which was probably a higher surgical database, Dr. Perry mentioned about surgery and that we sometimes ask things differently and maybe a little bit better, and that was reflected in what we saw, that in the surgery or non-LGS group, that it was a little bit better around asking around communication. So are there lessons to learn from that group? Of course, the answer is yes. Is that something that we do or reflect in our clinical trials? Maybe, maybe not, but that may be a group that we should tap into more. So we then used that information because it was important before we did this big portion of the grant to gather focus groups. We created focus groups around folks who had loved ones with LGS, and the LGSF helped us with that. And then we wanted to look at other advocacy groups that maybe intersect or overlap, like DEEP or Seizure Tracker or other kinds of areas, or Tuberous Sclerosis Alliance. So other areas that possibly overlap with LGS, but maybe not all have LGS. And then the third group were providers, some providers that are in this room, both for epilepsy specialists, but also a child developmental psychologist. And really what's important about that information is they informed each other. So we specifically started with the families because those were the people we needed to hear from first. And we used the information we gathered in our survey and asked them to reflect or resonate from that. And it was a really amazing opportunity to listen and hear. And what we thought we knew was different than what we actually learned. And I think that's another takeaway that I'm starting to learn from this project. But what I've really learned is that we need to hear from people who care for those with LGS. And it's important for us as medical providers in clinical care and also research to actually evaluate these other outcomes. We talked about today in trials, but what about the daily care? What about the patients who come see me in clinic? How am I assessing what's important to them and how that is impacted by the different treatments we recommend or try? And again, how can we use real-world evidence or existing data sets that help inform that and help us understand where we're coming from? The other thing is we need specific LGS instruments. So Randall and Scott talked a little bit about how they're approaching it from clinical trials. You're going to hear from the Instone group how that's helping us inform how to ask these questions from the DEE perspective. But I remember a conversation, and it's been kind of reminded of me today, from Houston, where Mary, our child developmental psychologist, you'll hear from in a little bit, we're sitting in Houston for an AES meeting, and we were sitting and lamenting with somebody who had to listen to me drone on about how it's not going to find these detectable changes in these trials because we're asking the wrong questions. We're giving the wrong instruments. And it was really profound when we did the Epidiolex cannabidiol studies because parents would routinely come up to me and say, hey, I'm seeing improvements, but you're never going to see that in this questionnaire because even though my child is 15, you're giving me a 15-year-old child questionnaire. He's at a 6-month level. He now looks like he's at a 12-month level because of this medication possibly or other things we're doing. And we were never going to see that. We were never going to notice that. And so I'm now really excited that there's a room full of people who get that concept and are going to change that. And I know that they're a lot smarter than I am and are going to do a better job, but I can't wait to use those things. But then there's also probably or most likely other domains that are important. So when we did these focus groups, the other things that came out, even though we were focused on behavior, quality of life, and communication, we were really interested in everything, but we couldn't look at everything, and we can't look at everything. But maybe that can set up some work in the future. Tomorrow, you'll hear from my friend, Dr. Shelhas and Dr. Gupta, about what they're doing and what their understanding is around sleep and how that's informing and important to patients and caregivers with LGS. But the other things that came out was GI issues. The number of patients who have feeding tubes or constipation as a trigger for their seizures. We all have heard that. How can we assess that? How can we look at that to see if things get better over time? One of the things I do at the American Academy of Neurology is I write a lot of quality measures. And one of the things I am proud of is that I help craft a quality measure with a lot of other people that looks at maintaining or improving quality of life. I feel like that's an important concept. And there's a lot that goes into that, partly seizure numbers, seizure frequency, seizure duration, which we talked about, but all these other aspects. And perhaps maybe looking at that domain more specifically will be helpful. I'm excited later to hear from Dr. Downs because I think the work that they have done around the CDKL5 assessments can be very informative and possibly helpful for the LGS community. But I think that's the other lesson I'm learning is that we got to continue to work together. They can't be silos. This meeting and the people who brought you here are really the epitome of bringing people together to work together. Yes, we can have our individual differences, and yes, we can sometimes disagree, but regardless, we have to put those aside. It's not about me. It's not about you. It's about them. And that's the important thing we have to remember. And then we have to say, you know what, providers, you got to do things uniformly. We got to agree in the medical community on exactly what is LGS, because you can't find in a database somebody with LGS if you're going to disagree on what is LGS. So, you know, I'm talking to now my colleagues. We have to decide and agree. The other big thing that we have to do is we have to actually document this information. Dr. DeLugos mentioned about like the EEG criteria. You know how hard it is to actually find slow spike wave written in an EEG report? I won't poll my friends in the audience. When I asked my colleagues at Nationwide Children's, do you always document slow spike wave in your EEG reports? Oh yeah, of course. I know you're lying because I have to review those reports and they're not there. It's so frustrating. So how can we get better on the data entry from the front end? How can we make sure that these kids have tonic seizures versus atonic seizures? You know, I'm part of the Pediatric Epilepsy Learning Healthcare System, and that is a solution for data entry that can help us standardize the way we do that. And we have to do that together. And I think it's important for the parents and caregivers and advocacy partners to make me do it. I need you to go to your provider and say, you should enter the data the same way somebody else does at a different institution so they can actually start working together and comparing. And you should document slow spike wave because that's such an important thing. And if you don't, we're gonna come get you. So I'm gonna put Tracy out there, and I know she'll do it. Because it's really important. I've learned so much by reviewing these chart reviews and how incomplete the data is. And when I go back to these centers and say, hey, send me snapshots of your actual EEG, it's clearly slow spike wave. It's clearly there, but nobody documented it. So a research coordinator is not gonna be able to interpret your EEG unless you have it in your report. Those are things I think that are important. So with that, I want to say thank you. This is one of my favorite pictures. We took this in Orlando, I believe. And I remember sitting outside working on the survey that was the beginning of all of this. And I get a little emotional because I remember sitting and making edits to that. We took this picture, and it's been an incredible journey to walk with Tracy. And what started as like just, hey, let's ask some questions to people who are in this group has now grown, and I hope it's going to continue to grow. And I hope it's going to continue with all of you and all of us together. So thank you for your time and your attention.